Welcome to the Anesthesia and Perioperative Medicine Channel review course. In part 3 of our Pediatric Anesthesia series, we're really moving from the textbook to the bedside, tackling the high-stakes clinical scenarios you're absolutely going to face in the OR. We'll be diving deep into everything from the most fragile neonates all the way to complex cases in older kids, and exploring how their unique physiology, pharmacology, and the surgery itself all come together to demand our absolute best. So here's our game plan for today. We're going to start with the absolute bedrock principles of neonatal care, and then we'll apply them to some really critical neonatal emergencies. After that, we'll talk about key surgeries in infants, then tackle some complex airway and thoracic challenges, and we'll finish up by looking at the highly individualized needs of some special patient populations. All right, let's jump in. You know, anesthetizing a neonate is really unlike anything else we do. The margin for error is just incredibly narrow. Their physiologic reserve is so limited that a patient who looks perfectly stable 1 minute can become critically unstable the next. And that just demands a level of vigilance and preparation that is, frankly, second to none. Our entire anesthetic plan really has to be built on these core principles. I mean, exhaustive preparation isn't just a nice idea, it's a flat-out necessity. Because once that baby is positioned and draped, your access is severely limited. That's exactly why every single line, every monitor, and especially that airway, has got to be absolutely bomb-proof. We have to be precise with every microliter of fluid and every microgram of drug. That means using infusion pumps to prevent overload and meticulously clearing every last bubble of air to prevent a catastrophic paradoxical air embolus through a PFO. And finally, aggressive thermoregulation. It's just not optional. A cold neonate is a stressed neonate, and that leads to acidosis, increased oxygen consumption, and potentially a devastating pulmonary hypertensive crisis. Now, interpreting our standard monitors in these tiny patients requires a really specific mindset. For end-tidal CO2, for instance, the absolute number might not be super accurate because of VQ mismatch and tiny tidal volumes, but the trend is invaluable for spotting changes or diagnosing something like an endobronchial intubation. On the oxygenation side, we're walking a tightrope, especially in preemies. Too much O2, you risk retinopathy of prematurity. Too little, you risk other neurologic problems. So a target of 93 to 95% is a pretty reasonable balance. But the biggest boogeyman here is triggering a reversion to transitional circulation. Any stressor, hypoxia, acidosis, even just being cold, can cause a sudden spike in pulmonary artery pressure, massive right-to-left shunting, and a downward spiral of collapse that's incredibly hard to break. This quote really gets to the heart of a core pharmacologic principle in neonatal anesthesia. The neonatal heart, it's just different. It's less compliant, it has reduced calcium stores, and it's highly sensitive to the negative inotropic effects of our volatile agents. Its function is much more dependent on heart rate, so this makes a balanced technique incredibly attractive. We can use a potent opioid like fentanyl or remifentanil to provide amazing analgesia and hemodynamic stability, and then just supplement with a tiny concentration of an inhaled agent to ensure amnesia. That way, we avoid significant myocardial depression. Okay, so now let's apply these core principles to some of the most challenging neonatal surgical emergencies out there. Each of these conditions presents its own unique constellation of anesthetic problems that really demand proactive management from us. So our first case is the repair of a meningomyelocele. This is a neural tube defect where the spinal cord and meninges are literally exposed on the baby's back. And while the surgical repair is focused right there, the anesthetic implications are systemic and they are complex. Let's break down our primary concerns here. First, positioning is tricky, right? We have to intubate while protecting that exposed neural tissue. Often, we're intubating the infant on their side or even supine on the edge of the bed before very carefully turning them prone onto chest rolls. Next, fluid and blood loss from that large, raw surface can be absolutely massive, and it's easy to underestimate. Large bore IV access and having blood in the room are non-negotiable. We also have to be vigilant for associated anomalies like the Arnold-Chiari T malformation, which can cause hydrocephalus and brainstem dysfunction that can show up as stridor or even apnea. And finally, please remember the high risk of future latex allergy. It is our responsibility to start latex-free precautions from their very first anesthetic. Next up, we're going to talk about abdominal wall defects. Now, while both omphalocele and gastroschisis involve herniation of the abdominal contents, it is absolutely critical to understand that they are fundamentally different conditions. They have vastly different anesthetic implications, and that's largely driven by their associated anomalies and their underlying pathophysiology. This comparison is really the key to our management. With gastroschisis, you've got exposed bowel, so it's primarily a fluid and electrolyte problem. You're dealing with massive insensible losses and inflammation from all that amniotic fluid exposure. Omphalocele, however, is a different beast entirely. While the organs are contained in a sac, it carries a very high incidence, up to 60%, of associated anomalies. Most critically, about 20% have congenital heart disease. It's also linked with syndromes like Beckwith-Wiedemann, which brings its own challenges like hypoglycemia and macroglossia. So the bottom line is, when you see omphalocele on the chart, your brain should immediately think full workup, especially a screening echocardiogram. So this slide really lays out our game plan. Step 1 is the most important one. These are not surgical emergencies. The number one priority is medical stabilization. We have to aggressively resuscitate with fluids and fully work up the patient. Intraoperatively, our goals are to maintain that stability with large bore access and to really help the surgeons by providing profound muscle relaxation for the closure. You have to anticipate problems during that closure, like the vena cava getting compressed, causing hypotension and needing really high peak airway pressures. And then postoperatively, the battle's not over. You have to expect prolonged ventilation and be super vigilant for abdominal compartment syndrome, a truly life-threatening complication where that high intra-abdominal pressure compromises perfusion to the kidneys, the gut, and the liver. Okay, on to our next big challenge, Tracheoesophageal fistula, or TEF. This is that abnormal connection between the airway and the esophagus. And just like omphalocele, it's frequently associated with a whole constellation of other anomalies that we know as the vectoral association. The anesthetic problems here are really significant. These infants often come to us with an aspiration pneumonitis already on board from pooled secretions. That fistula creates this low-resistance pathway for gas to just pour into the stomach during positive pressure ventilation. This can lead to massive gastric distension, which can then impair your ventilation and venous return. On the flip side, if the fistula is really big, your tidal volumes can get stolen right down the esophagus, making it impossible to ventilate the lungs. And again, with that vectoral association, we always have to hunt for and manage any associated cardiac defects. This right here is the single most important sentence in the management of TEF. Everything we do is aimed at achieving this one goal. And this is exactly why an inhalational induction, maintaining spontaneous ventilation, is the go-to technique. It allows us to secure the airway with an endotracheal tube, carefully position it past the fistula but before the carina, before we apply any positive pressure. This prevents that gastric insufflation, and it lets us control the airway and ventilation from the very beginning. All right, our final neonatal emergency is congenital diaphragmatic hernia, or CDH. And it's so important to understand that in CDH, the surgical defect itself is not the primary problem. The real life threat is the severe pulmonary hypoplasia and the persistent pulmonary hypertension that result from having all those abdominal contents developing up in the chest. This table really outlines the modern physiology-driven approach to CDH. And critically, in the preoperative phase, the mantra is stabilize first. We do not rush these babies to the OR anymore. Instead, we use advanced therapies like ECMO and nitric oxide to optimize their pulmonary vascular resistance. Intraoperatively, our entire focus shifts to avoiding anything that could trigger a pulmonary hypertensive crisis. So, meticulous avoidance of hypoxia, acidosis, and stress, often with a high-dose opioid technique. And finally, for ventilation, we avoid bag masking like the plague, and nitrous oxide is absolutely contraindicated because it will just diffuse into and distend that herniated bowel, further squishing the already tiny lungs. Okay, so moving into the infant period, we're shifting gears a bit from those big congenital emergencies to common but still high-risk procedures. Here, the anesthetic challenges often center more on correcting preoperative metabolic messes and managing very specific postoperative risks, especially apnea. This quote is really the cornerstone of safe anesthesia for pyloric stenosis. That persistent projectile vomiting leads to profound dehydration and that classic hypochloremic, hypokalemic metabolic alkalosis. Taking this patient to the OR before correcting it is just a recipe for disaster. And why is that? Well, that persistent alkalosis actually blunts the central respiratory drive, making postoperative apnea a major risk. Our job is to insist on complete medical optimization first. So let's walk through the key concerns. First, that metabolic picture we just talked about. Resuscitation with normal saline that has potassium in it is key, and our goals are to fix the dehydration and normalize the electrolytes. Intraoperatively, our number one risk is aspiration. These infants have a stomach that's just full of curdled milk. We absolutely have to suction it with a large bore catheter right before a modified rapid sequence induction. And finally, postoperatively, even after a perfectly smooth case, we have to monitor them so closely for apnea because that risk is directly tied to how well we corrected their metabolic state beforehand.
Now for one of the most common procedures in all of pediatrics, the infant inguinal hernia repair. Its frequency can kind of lull you into a false sense of security, but for one very specific patient population, the former preemie, this procedure carries a really significant anesthetic risk.
This number is the single most important piece of data you need for risk stratification. Post-menstrual age, which is just the gestational age, plus the chronological age, is the key determinant of risk for post-operative apnea. Any former preterm infant with a PMA of less than 60 weeks is at high risk, period. So here are the other major risk factors. A lower gestational age at birth and being anemic further increase that risk. Anemia is especially concerning because with less oxygen carrying capacity, they desaturate much faster during an apneic spell. Now, there's been a lot of debate about whether an awake regional technique like a spinal is safer than general anesthesia. But here's the bottom line. While a spinal might have some immediate benefits, the risk of late apnea persists. So the crucial point and the current standard of care is this. Any infant who meets these high-risk criteria must be admitted overnight for apnea monitoring, no matter what anesthetic technique you chose. All right, shifting our focus now to the older kids, we're going to tackle a set of conditions where the airway is really front and center. In these cases, airway compromise isn't just a risk, it's the central theme of the entire perioperative period.
I want you to just picture this clinical scenario. You're presented with a child for a biopsy of an anterior mediastinal mass. They look totally fine, they're breathing comfortably. What is the single greatest danger we face at the moment of induction?
The answer is stark. Sudden, catastrophic, and potentially irreversible cardiorespiratory collapse. The loss of chest wall tone with induction and muscle relaxation can allow that mass to completely obstruct the trachea, the bronchi, or even the great vessels like the pulmonary artery. So safe management requires a really meticulous multi-step protocol. First, CT and echo are not optional. They are mandatory. To define the anatomy of the compression, we need to know exactly how much the trachea is narrowed and if there's any compression of the heart or great vessels. Second, our anesthetic technique has to mitigate that risk. This means maintaining spontaneous ventilation with an inhalational induction and avoiding muscle relaxants at all costs. Third, we have to be prepared for the absolute worst. The surgeons need to be scrubbed with a rigid bronchoscope ready and maybe even ECMO on standby. And finally, if that imaging shows severe compression, we have to be the patient's strongest advocate and push for a diagnosis under local, avoiding general anesthesia altogether. Next up is another common pediatric emergency, the inhaled foreign body. This procedure, a rigid bronchoscopy for retrieval, is a true team sport. The success and safety of the case really hinge on seamless collaboration between us and the surgeon. This quote really says it all. We are sharing the airway. The surgeon is literally working through our ventilation path. This requires a super dynamic plan, often involving periods where we have to stop ventilating so the surgeon can grab the object, followed by periods of ventilation. We need a shared mental model, constantly talking about oxygenation, ventilation, anesthetic depth, and the surgical plan. Any breakdown in that communication can lead to disaster. All right, let's talk about one of the most common surgeries performed in children, tonsillectomy. And we're going to focus specifically on the group that poses the greatest anesthetic challenge, and that's kids with significant obstructive sleep apnea, or OSA. Let's break down the three major areas of concern. First, the patient themselves. Kids with severe OSA have a blunted response to CO2, and they are exquisitely sensitive to the respiratory depressant effects of opioids. Our management has to involve very careful opioid use, often supplemented with non-opioids like dexmedetomidine, and we have to admit high-risk patients. Second, the emergency. A post-op bleed is a life-threatening event. We have to treat this as a rapid sequence induction in a hypovolemic patient with a stomach full of blood and anticipate a very difficult airway. Finally, the controversy, which isn't a controversy anymore. Codeine is absolutely contraindicated. The FDA has a black box warning because of the risk of death in kids who are ultra-rapid metabolizers and convert codeine to dangerously high levels of morphine. Just don't use it. For our final section, we're going to turn our attention to two special populations that require highly individualized and really thoughtful anesthetic plans. These are cases where understanding the underlying disease process or the child's unique needs is absolutely paramount to providing safe care. A muscle biopsy might seem like a straightforward peripheral procedure, but for the anesthesiologist, it is just fraught with potential danger. The whole reason for the biopsy is a suspected myopathy, and our choice of anesthetic agents can have profound and sometimes fatal implications for a patient with an undiagnosed neuromuscular disease. This table is so critical. First, succinylcholine is absolutely 100% contraindicated. The risk of fatal hyperkalemic arrest in muscular dystrophies is real. Volatile agents are known triggers for malignant hyperthermia, and they're also associated with rhabdomyolysis. Even propofol carries risk, particularly in suspected mitochondrial disease, and it might even interfere with the biopsy results. So the crucial takeaway is this: there is no single safe anesthetic. The plan has to be meticulously tailored to the suspected diagnosis, often involving a trigger-free TIVA technique and regional anesthesia, and always in consultation with a neurology team. Finally, let's discuss our approach to the child with a developmental disability. This is an incredibly diverse group of patients, and a one-size-fits-all approach is just guaranteed to fail. The key to success is a patient and family-centered approach from the very, very beginning. This quote captures the most important principle of all. The parents are the experts on their child. They can tell you what soothes them, what frightens them, how they communicate. Involving them early in the planning process, talking about pre-medication strategies, and even allowing a parent to be present for induction can completely transform the perioperative experience, making it both safe and humane. And this slide just illustrates perfectly how we have to tailor our approach. For a child with autism spectrum disorder, our challenges are primarily behavioral and sensory. We need to create a calm environment, rely on routines, and use the communication strategies the parents suggest. But for a child with cerebral palsy, the challenges are often profoundly physiological. We have to manage poor nutrition, GERD, chronic respiratory issues, potentially difficult airways, contractures that make positioning hard, and a high risk of hypothermia. The entire focus shifts from behavioral management to complex medical management. We've covered a huge amount of material today, from the unique physiology of the neonate to the complex challenges of specific diseases. So as we wrap up, I want you to think about this question. What is the single unifying principle that ties all of this together? And here it is. The answer isn't one specific drug or a single technique. It's really a philosophy built on 3 pillars. Constant vigilance, because our patients can change in a heartbeat. Meticulous preparation, because we have to be ready for absolutely anything. And a deep, foundational understanding of developmental physiology, because children are not just small adults. Thank you very much for your time and attention.